I thought it was a great conference. I'm always impressed. I guess I shouldn't be because they have such great speakers and they really do a great job of getting people across the industry and a lot of veterans to come and speak. But I'm always amazed at the level and depth of content that is available at these conferences. And there was so much to talk about. There was a lot of focus on concerns around audits, especially with the emphasis that we know we heard last year from OIG on looking for particular codes that are potentially overused or inappropriately, erroneously used. There was a lot of talk about data, how to use patient data to drive outcomes and to drive engagement. But I think the overarching theme that I thought was the biggest takeaway was this concern about V28. And I don't want to make light of it. I know a lot of folks are very concerned at what their revenue is going to look like related to risk adjustment reimbursement. And one of my colleagues was citing that several of his groups have found anywhere from 8 to 30% depreciation in revenue. And, I was just thinking that while risk revenue may be declining, I really think it's important that we think about the program overall. And that was a lot of the conversation, or at least it was, I had the ability to participate in 3 sessions, and I know that that was the message that I wanted to carry. And I heard it from others too, that I don't want to make light of risk revenue going away or, say that it's not, it is going to depreciate. However, I do think that there are other opportunities. And and here's the thing too. I think in the past, I'll talk about the opportunities in a second, but I think in the past, we were grateful for the reimbursement that we received. We submitted the code, we were reimbursed, but I think and apologies for using the collective we, maybe that's not appropriate, but I know that in hearing talk about it is that the reimbursement that you got from those codes became expected. And what we didn't think about maybe, or not all of us, was that there was something that was owed from that we needed to provide care programs and actually do things to mitigate the exacerbation of those diseases. So finding diabetes with complications in and of itself was not enough, that we really needed to take it a step further and implement programs and ensure med adherence and all these other components, regular screenings, A1C control and education, all these programs that we were expected to do with that reimbursement. And maybe some of us did, and maybe there were some of us that didn't. And I think that this is just an evolution of the program. And so while, yes, your risk revenue may decline or decrease than what you had experienced in the past, you really need to think holistically and how the pieces of the puzzle really knit together, if you will. And so looking at those total cost of care programs, making sure that you're addressing your quality measures, doing things to try to offset that typical or what we would expect of the disease trajectory, and in order to save costs there, while potentially experiencing lesser reimbursement on the risk side. The other thing though that I would want folks to pay attention to too is think about the opportunities where we could get better. And so while there may have been some conditions that folks went to in the past, we're really looking at how do we document the health of that patient. And so knowing that personality disorder has been expanded and a light shown on that and behavioral health, I think that there's greater opportunities. We know that we probably only capture about half of personality disorders that are prevalent in the population. And so there's opportunities there. Also to the number of conditions. So there's a lot of different factors. So if you were to take apples to apples and compare V24 to V28 and what your reimbursement was and what you could expect, would there be a difference? Absolutely. But I think if you look at where you can get better in the program, not only from accurately documenting and capturing those conditions, as well as we talked a lot about revenue timing and making sure to submit data timely so that you had monies to fund those programs, and then truly running successful programs. I think that you'll find that the pinch that everyone believes that they're going to feel or are feeling would be ameliorated, and you wouldn't have the effects that a lot of folks, I think, are dreading. I want to just expand a little bit on the data timeliness. There was a lot of talk about that, and I think it goes again to managing care. And so making sure that you're seeing patients, it shouldn't just be about that annual wellness exam for your Medicare Advantage patients. You really should be seeing your patients. We know that seniors should be seen at least 5 to 8 times a year, and that someone's condition can change pretty quickly when they're of advanced age. And so where you are in your life in February as a 72-year-old can be dramatically different as to where you are in August. And there are opportunities in risk operations to make sure that that patient is seen and assessed. If you saw them in February or March, you wouldn't catch up, right? Or you wouldn't have complete data on where they were in that August timeframe. But the thing is if you were able to capture that data pretty much real time, submit that data, you would be able to true up your revenue and your reimbursement. We know that the first 6 months of a year in submissions, so say the last 6 months of 2022 and the first 6 months of 2023 went into our September sweeps here that we just had in 2023, and that will then set the reimbursement or the rates that we could expect in January. And again, that all has to do with funding our programs. And so, again, I think it's overall the theme was being diligent, making sure that we're paying attention to accuracy. There's an onus on us to get better at what we do, to be more tactical, to be more strategic, to see those patients and provide the care that we've been reimbursed for many, many a year. And we can continue to, I think, expect those same benefits, but it's going to take it's going to take work and a lot of thought. And so those are my takeaways from the 22nd RISE Risk Adjustment Forum. Great conference. Few things. I'm never short on words, I think, but with the transition, just a few best practices that I would recommend is make sure your systems are set up to accommodate both models. We know that it's a phase in, and you would want to make sure that you're still calculating and accounting for V24 as well as V28. Knowing that navigating those critical points can be challenging, I would advise you to take snapshots of your databases, at least on a monthly basis, so that you have that historical view in the event that you needed to go back and do some type of, analytics. Would highly recommend that. And then I would say, data in data submissions. If you're not already looking at a platform or a program where you and ideally provide insights at the point of care so that we can maximize those visits, so that we're not relying on an annual wellness visit to capture everything, but multiple visits across the year. But to the extent that we can provide that data for those clinical insights and that documentation, and seeing patients, like I had mentioned, on a regular basis, and providing programs that are truly intended to manage conditions and prevent them from exacerbating in a way that we typically or traditionally expect, I think are important. And there was a lot of talk too about preventative screening. I know a lot of folks think that things like peripheral vascular disease are going away. But one of the things I know I shared in one of the segments that I did was there's actually studies that indicate that PAD without complications, once you get that asymptomatic diagnosis, it's not a very long walk to complications. Actually, it's about a year for manifestation of resting pain, which would allow you to capture that PAD with complications. And I think that's the perfect example. If you're doing that preventative screening and you're capturing that condition early, you have that in your data. You're able to track for it, to be able to note, when it becomes complicated. And so, doing work like that, making sure that you are proactive in recording a patient's health and that you're monitoring it so that when you do have an exacerbation, that it's being recorded promptly so that you're getting the appropriate reimbursement will be important, and that timely data submission. And so going back to what I was saying about the data platform, having something that is aggregating all the data, can consume the data and read it, not easy to do, but can consume the data, read that data, put it together, that it makes sense so that data doesn't fall out, and that it makes its way to the clinician, that it's integrated in a way that is helpful, not a lot of noise, not every single, code imaginable on a patient or things that have resolved, but really being smart about what's presented and then taking that data and making sure that it, it's like a game of operator, making sure that it proceeds down the line in a way that keeps it as whole as possible. That's important, right, to advancing that patient care and interoperability. And so making sure that that data that comes from the physician gets passed to the health plan, goes on to CMS, and in all those junctures gets accounted for and reported adequately and accurately. So I've had experience with both. And I can tell you maybe about 7 years ago, so not that far distance past, having conversations with a president of a university medical center who said to me, well, we don't, I'll choose my words, that seeing patients went against their capitation arrangement and cost them money. And the thing is again, right, it's the reversal. We need to be, rather than reactive, be proactive and see patients. It's trying to prevent conditions as opposed to responding to symptoms. And to the extent that they should be seeing their patients, it shouldn't be seen as a burden or a cost, but rather a way to offset cost. And one of the examples I know that I shared in one of my sessions too is that, it very quickly, I modeled out looking at COPD and depression. And if you take that patient and you record them, the reimbursement over 100,000 Medicare Advantage lives is a little over, I think it was 5 million. But anyway, what I was able to demonstrate is that if you look at prevalence of COPD in the population 65 and older, it's about 10.5%. And so over that 100,000 lives, it leads to about 10,500 patients that have COPD within your patient population, plus or minus, but just looking at prevalence rates. And then if you take that and you look at what the average is for a one-night stay, inpatient stay for a COPD patient in a given year of that 65 and over population, it's 29.1%. So it's a little over 3,000. I think it's like 3,600 patients within a given year that we can expect with that diagnosis of COPD in your patient population of 100,000 to have at least a one-night hospital stay. Well, that cost outpaces the cost that you would receive in reimbursement. So if you're not doing something to avoid those admissions, maybe providing a home care program or an after hours nurse line, if you're not providing those types of components, educating your patients on what urgent cares are, what people with COPD that may have an exacerbation might do, encouraging flu vaccines, encouraging pneumonia vaccines, all the things that we can do that we know could help prevent that patient from having that episode it's far more worth it than any reimbursement that you're going to see. And so if you're not doing those things, you're definitely going to be operating in the red. And so that would be my recommendation. Don't think about the short-term gains of what you're going to get in your risk reimbursement, but think about, the long-term gain of balancing risk revenue reimbursement with any types of returns, and then the benefits of managing those patients. And not only are you going to save money, but people are going to have a better experience. You're going to have better patient satisfaction and outcomes. And we all have loved ones too. And so I think, providing better care and better health outcomes is really the goal. And that's what we should be looking at. The other things that come along with that, like reimbursement, are just a benefit. The role of medical leaders then is to encourage, again, that proactive behavior and looking to preventative care as opposed to being reactive or responding to symptoms. So really getting ahead of patients having health issues. Hostility, no, change is hard. I think we just need to look at how we need to look at organizational theory and how change occurs. If you think about when we all went to smartphones, right, and technological adoption, there's always going to be people at the front of the curve. There's not going to be a lot, but there will be people that will be the trendsetters and blaze paths, right? And then you'll have the majority of people coming along. And I think you see that all the recent legislation, the AHEAD model, which really focuses on hospital and hospital cost, as well as a lot of the other programs out there, are really designed, I think, to move the middle of the pack, if you will, into adoption. And, the plan is by 2030 that groups will be involved or, will be covered by a value-based care contract. And so I think a lot of the legislation that we see is driving that. And then there will always be naysayers. There will always be people that complain, but change takes time. It's an evolution. I don't think we should expect it to happen overnight. But I think that, that it'll be gradual. And so while there might be some people that are off-put by the changes, at some point they'll either come along or they won't. You also asked me about physicians that are not employed and independent practice. And I am a champion of the independent physician, and I think that they are so important. I think that having individual voices be respected and accounted for out there in healthcare are a must. Having large, big box organizations dictate patient care, I think we need a way to challenge that. And I think that that's done through the independent physician. And I'm excited. I know it seems like a lot of work, but I think that it gives a lot of autonomy and empowers and gives agency to those independent physicians. And if you have the right tools, I know I've talked a lot about data. If you have the right tools, it can make things better. And I know, and I know I've shared this before, I'm not a physician, but I recall a conversation that I had with a friend of mine who was a primary care physician, is a primary care physician. And one of the remarks that she made, because she was tired, and I said to her, I said, well, why is that? And her response was that she felt like what she signed up for, she wasn't really getting to do. And so being able to take care of patients that are truly sick that needed her care, that she wasn't able to do that. And that the way our healthcare system was, as far as like restricting access and being able to do the things that they know are important for the patient, um, was a challenge. And so I think that these types of programs permit that, provided you have the right technology, right? And that we're able to provide the right resources. So I think that that's what you're seeing out there in these wide scale, wide sweeping changes around interoperability, around requirements around documentation, around prior authorization, all the different components, the transparency, right, of cost. When I think about all the changes that have been made, and then bringing together all the technology that we have, is that intersection is going to be so critical for our independent physicians to continue to do the good work that they're doing. And I see them as being a very primary, necessary part of the process, and want to do everything to support them, because we need their voice out there in the community.